This lecture is going to go over analgesics. Specifically, we have a little introduction to pain and talk about acetaminophen and opioid analgesics. So pain is considered the fifth vital sign. There's some just basic definitions you want to know in relationship to pain, pain threshold being one. An individual's pain threshold reflects the level of stimulus needed to create a painful sensation. An individual genetic makeup contributes to the variation in pain threshold from person to person. Pain tolerance, the amount of pain a person can endure without having to interfere with normal function. Analgesics should be a term you're familiar with. It means pain relieving. Analgesics are divided into either opioid analgesics or non-opioid analgesics. Nociceptors are sensory receptors for pain. They're activated by noxious stimuli, whether it's mechanical, thermal, or chemical, in peripheral tissues. Neuropathic pain is an unusual sensory disturbance that often involves neural supersensitivity. The pain is due to injury or disease of the peripheral nervous system or central nervous system. The patient with neuropathic pain usually complains of burning, tingling, or electric shock sensations in the affected area, often triggered by light touch. An example of neuropathic pain would be diabetic neuropathy in our patients with diabetes. The gate control theory describes how pain is perceived. A painful nociceptive stimulus stimulates primary afferent fibers and travels to the brain via transmission cells. Increasing activity of transmission cells results in increased perceived pain. On the other hand, decreasing activity of transmission cells reduces perceived pain. In the gate control theory, a closed gate describes when input to transmission cells is blocked, therefore reducing the sensation of pain. And an open gate describes when input to transmission cells is permitted, therefore allowing the sensation of pain. There are different types of pain, and you want to be able to describe these. Acute pain occurs suddenly and for a short duration, less than 3 months. Response to treatment can result from trauma, tissue injury, inflammation, or surgery. Chronic pain persists for longer than 3 months and is difficult to treat or control. Cancer pain is pain caused by cancer. It occurs from pressure on nerves or organs, blockage to blood supply, or metastasis to bone. Somatic pain is pain in skeletal muscle, ligaments, and joints. Where visceral pain is pain from smooth muscle and organs. Superficial pain is from surface areas such as skin and mucous membranes, where vascular pain occurs from vascular or perivascular tissues, contributing to headaches and migraines. Undertreatment of pain occurs in up to 75% of patients. The reasons for undertreatment of pain, there's a lot of different types of reasons. Some reasons for undertreatment are socio-cultural variables that mediate a patient's willingness to acknowledge being in pain. Maybe it's a cultural thing that they try to be stoic and not admit they're in pain. Other reasons could include the patient's inability to describe pain, fear of addiction, nurses' inability to measure pain or not regularly assessing pain, attitudes from a healthcare team, unwillingness of nurses and physicians to believe the patient's report of pain, inaccurate knowledge on the part of the healthcare provider concerning addiction and tolerance, and prescription of an inadequate analgesic dose. The effects of unrelieved pain lead to a multitude of harmful effects that involve almost all organs of the body. As a result of unrelieved pain, the patient may have increased respiratory and heart rates, hypertension, increased stress response, increased blood glucose levels, electrolyte imbalances, fluid overload, urinary retention, paralytic ileus, weakness, confusion, and infection. Non-opioid analgesics are less potent than opioid analgesics. They're used to treat mild to moderate pain. They can be effective for dull and throbbing pain of headaches, dysmenorrhea, minor abrasions, inflammation, muscle aches, pain, mild to moderate arthritis. They work on the peripheral nervous system at pain receptor sites. NSAIDs is a type of non-opioid analgesic, and we're not going to lecture over NSAIDs because we have already covered those. Acetaminophen is another type of non-opioid analgesic. Acetaminophen is not an NSAID, so it's a non-opioid analgesic, but acetaminophen is not like ibuprofen, not like aspirin, because it is not an NSAID. It works by inhibiting prostaglandin synthesis. It's used for muscle aches, pain, and fever. Max dose is something that's important to know for acetaminophen. The max dose is 4 grams or 4,000 milligrams. So we want to keep track of what's been ordered for the patient or what a patient's telling us they're taking on their own at home, because the max daily dose for acetaminophen is 4 grams or 4,000 milligrams. If a patient is taking a dose that exceeds that amount, we'd be worried about the liver function. Okay, so an overdose of acetaminophen can be extremely toxic to liver cells and lead to hepatic necrosis. So the 4 grams per day, and we're worried about the liver. Let's see, acetaminophen is safe, effective when used at therapeutic doses. It causes little to no gastric distress, and does not interfere with platelet aggregation. So that's a way that acetaminophen is different from ibuprofen. Since it's not an NSAID, it doesn't cause GI distress, and it doesn't interfere with platelet aggregation. Side effects for acetaminophen, again, lower incidence of GI distress when compared to NSAIDs. Some toxic effects, hepatotoxicity. Again, we're going to definitely want to be watching our liver function in our patients who are taking acetaminophen. We're also going to want to look out for our patients who have problems with the liver, so an alcoholic or a patient with hepatitis. We would not want them to take acetaminophen because their liver is already not functioning properly. We're going to watch kidney function also, and then monitor for thrombocytopenia, anemia, granulocytosis, just monitoring those lab values for the patient. In terms of acetaminophen, again, we're going to look to see if our patient has a history of liver dysfunction. We're going to assess our pain severity, and we're hoping, the planning there, we're hoping that the patient's pain will be relieved and minimum diminished due to administration of acetaminophen. So nursing intervention, check liver enzymes. Teach patient to keep acetaminophen out of children's reach. Teach patient to avoid alcohol when taking acetaminophen. Report side effects. Check serum acetaminophen level if toxicity is suspected. The therapeutic serum level for acetaminophen is 10 to 20 micrograms per milliliters. So again, acetaminophen has a therapeutic serum level, so that value is something that you need to have memorized. So the therapeutic serum level for acetaminophen, which is Tylenol, is 10 to 20 micrograms per milliliter. Acetaminophen also has an antidote. So anytime we talk about a medication that has an antidote, you need to have that antidote memorized. So if somebody overdoses on acetaminophen, the antidote is acetylcysteine. Dosage is based on the serum acetaminophen level. So acetylcysteine, acetylcysteine, acetylcysteine. Opioid analgesics are used to treat moderate to severe pain. Many opioids possess antidiarrheal effects. They may also be used as antitussives, anti-cough medications, antitussive. The action site for opioids is the CNS. If you remember, with the non-opioids, the action site was the peripheral nervous system. Opioids affect the central nervous system. They suppress pain impulses, suppress respiration and cough by acting on the respiratory and cough centers of the medulla. They are contraindicated in patients with head injury. Again, the opioids are affecting the central nervous system. So some of the side effects we see is because the medication, morphine is your prototype medication, is affecting the central nervous system, drowsiness, dizziness, euphoria, confusion, all affecting the central nervous system. It's not that peripheral nervous system, but actually the brain that's being affected. Miosis is a term you should know. It means constriction of the pupil, can affect vision. GI distress, constipation is a big one. Our patients taking opioids are at risk for constipation, so we're going to want to evaluate that. They're at risk for hypotension. Orthostatic hypotension is when the patient experiences hypotension when they stand, putting them at risk for falling. It's a safety issue. Weakness, urinary retention, respiratory depression. So just in general, you could say that everything gets turned down. The respiratory system gets turned down, respiratory depression. Blood pressure gets turned down, hypotension. The brain gets turned down. We've got drowsiness, confusion, urinary retention and constipation, right? Every body system seems to get shut down a little bit. Prior to administering morphine, we're going to want to check the drug history, look for allergies, assess the type of pain, location, duration of pain before giving any opioids. We want to assess the pain, so get a rating using whatever pain scale we're using. Nursing diagnosis, breathing pattern. So we want to make sure that we're checking our patient's respiratory rate before giving an opioid, because again, opioids such as morphine can lead to respiratory depression. And if I have a patient who already is not, doesn't have a normal respiratory rate, right, I could cause some big damage by giving them morphine, which is going to make them breathe even less, right? And the goal would be that the patient's pain would be reduced or alleviated. In terms of morphine or opioids in general, it's important to know there is an antidote for an overdose. Generic name is naloxone. It's going to be what we're going to talk about. So the antidote for morphine excess or overdose is the opioid antagonist naloxone. Meperidine is another type of opioid analgesic. Brand name is Demerol, for those of you who are familiar with that. Meperidine is preferred to morphine because it does not diminish, in pregnant patients, because it does not diminish uterine contractions and causes less neonatal respiratory depression. Meperidine causes less constipation and urinary retention than morphine. Meperidine is not indicated for patients with chronic pain, severe liver dysfunction, sickle cell, a history of seizures, or severe coronary artery disease or cardiac dysrhythmias. When older adults and patients with advanced cancer receive large doses of meperidine, neurotoxicity is reported. It includes nervousness, tremors, agitation, irritability, and/or seizures. Meperidine should not be prescribed for long-term use and is frequently limited to 48 to 72 hours. Meperidine is metabolized in the liver to an active metabolite, therefore the dose should be decreased for patients with hepatic or renal insufficiency. Meperidine should not be taken with alcohol or sedative hypnotics because combination of these drugs cause an additive CNS depression. Hydromorphone is another type of opioid analgesic. Brand name is Dilaudid, for those of you who are familiar. Hydromorphone is a semi-synthetic opioid similar to morphine. The analgesic is approximately 6 times more potent than that of morphine, with fewer hypnotic effects and less GI distress. All the opioids we've discussed so far, hydromorphone, meperidine, and morphine, are all Schedule II narcotics. Side effects are similar to the other opioids: drowsiness, dizziness, confusion, weakness, constipation, miosis. Being an opioid, we worry about tolerance dependence, respiratory distress, depression, urinary retention. And again, hydromorphone has fewer hypnotic effects and less GI distress than morphine. Respiration should be monitored closely and adequate hydration should be provided.